Welcome to virtual session number 5, Rectal Cancer Response to Neoadjuvant Treatment. Does tumor size influence response? Today's presenter is co-author of this published article, Quentin Denost, and the moderator today is our own Techniques in Coloproctology Associate Editor, Guillermo Pahin Sao Juliao.
Yes, absolutely. So 5 p.m. Eastern Time, I'm talking from Brazil. My name is Guilherme São Julião. I am one of the associated editors of Techniques in Coloproctology, and I would like to welcome everybody to this virtual session. Dr. Perez is connecting shortly. Unfortunately, he is on a flight that was delayed, and I'm sure once he lands, he will connect. So today we're going to have Dr. Quentin Denost, which is a colorectal surgeon in Bordeaux, France, with large experience in organ preservation for rectal cancer, one of the leaders of the GRECAR studies, who will be presenting for us one of his recently published studies in Techniques in Coloproctology. Quentin, it's all yours.
Hi, Guilherme, and thanks for giving me this opportunity to show and to highlight our results, which has been recently published in your journal. So I will share my screen. Please, can you confirm that you see my first slides?
Yes, we can see it.
Yeah, okay. So the title of this recent paper is Tumor Response Rate Based on Initial TME Stage and Tumor Size in Locally Advanced Rectal Cancer, a useful tool for shared decision making. And this is the first point. This, in introduction, I would like to say that this paper highlights both topic, tailored treatment and shared decision making. Tailored treatment because obviously we need nowadays to propose to the patient the more precise and tailored treatment for each stage according to the type of chemotherapy, to the radiation, and obviously to surgery or no surgery and organ preservation strategy. And then obviously the shared decision making, because we need and probably will move more and more forward this way in rectal cancer. We need to share the decision with the patient. But before sharing this decision, obviously, we need to have all this information and to have very precise information in the treatment we can propose to them. The prerequisite in shared decision making is to propose equivalence of the different strategy, equivalence at least in oncological results. And I think that this paper, the GRECAR2 trial published nowadays 4 years ago, showed that with a selective approach in organ preservation, we are able to propose the same overall and disease-free survival in patients with organ preservation, with local excision, or with TME in case of good response. And this is a beginning and the prerequisite of shared decision-making, meaning that we can propose two strategies with the same oncological results. And then obviously we will discuss with the patient benefits and inconvenience of both strategies. And in this selective approach, you can see here the last randomized clinical trial. And you can see that the rate of organ preservation in this all randomized clinical trial varied from 50% to 80% at 3 years. And you can see that the inclusion criteria are quite similar from T2 to T3 and 0 and 1, smaller than 4 centimeters. But it's really important to define more precisely, even in this selective approach, the result of each step according to the stage and according to the size of the lesion, because we can assume that maybe for the T2 and 0, 2 centimeters, results of organ preservation will not be the same that for the T3N1 of 4 centimeters, whereas they are all pooled together in all these randomized clinical trials. So the aim of our paper was to evaluate the complete response and near complete response rate after neoadjuvant treatment for mild and low rectal cancer according to both tumor size and tumor stage. So it was a single center cohort study with patients included from 2014 to 2021. Inclusion criteria were CT2, T3, and 0 and 1 from 0 to 8 centimeters from the anal verge. The MRI were interpreted according to the Greca-French Radiology Group recommendation, which has been published. All patients receive long course chemoradiation, and some of them had induction chemotherapy due to the French attitude. And in our policy, we use more induction than consolidation chemotherapy, as you know, and we use from 4 to 6 cycles of FOLFIRINOX before the long course chemoradiation. The tumor response were assessed 6 to 8 weeks after the end of neoadjuvant treatment with clinical examination and MRI. We assess the tumor response through this response surveillance program, cover a 6 months period of time, and we assess the tumor response at 2 months, 4 months, and 6 months, and we define a watch and wait strategy only after 6 months of follow-up in case of complete clinical response. If there is a subcomplete clinical response, patient had a local excision. That means that in all our cohort, we have patient with a rectal excision with TME, APR, or pelvic exenteration, and patients with organ preservation, combining both local excision and watch and wait according to the complete or subcomplete tumor response. At the end, we divided the patient in non-responders, meaning poor response, YPT2, T3, or N positive, defined by a residual locally advanced tumor with or without metastatic lymph node in surgical specimen, and the responders group with complete clinical or pathological response and near complete pathological response. So regarding the results, you can see that we have included 432 patients. The majority of patients were male. The median distance from the anal verge was 5 centimeters. 80% of patients had MRT3, 2/3 was N positive, and the majority of patients had long course chemoradiation without induction chemotherapy. Only about 1/4 of our population had an induction chemotherapy. You can see that non-responder group represent about 65% of the population and the responder about 35%, with a majority, 2/3 of complete pathological or clinical response and 1/3 of near complete pathological response. The tumor size cutoff were defined by performing a ROC curve analysis with a single optimal at 4 centimeters to distinguish responder from non-responders, meaning that the patient with a lesion smaller than 4 centimeters had a higher chance, significantly higher chance, to obtain a good response with a complete or near complete response. If you have a look in the complete response, you can see that the majority of patients had induction chemotherapy. And what is really interesting is the tumor stage. You can see that we moved from 50% of complete response for T2N0 to lower than 20% in case of T3 and positive. And this is the same according to the tumor size, from 42% to 16% if you compare patients with a lesion smaller than 3 centimeters or bigger than 4 centimeters. And all of these are significantly different. Then if you pull together the complete and near complete response, what we called the responders group, you can see that same. The majority of patients had an induction chemotherapy, and we can achieve in a T2N0 almost 80%, 76% of responder, and then only 25% of responder in patients initially who had a T3N1 stage. And if the patient had a tumor size smaller than 3 centimeters, the responder group were 65% against only 20%, about 20% if the lesion was bigger than 4 centimeters. If you pull it together, all this information in this infographic data, you can see that we move from 77% of responders in T2N0 smaller than 3 centimeters to 20% in T3N positive bigger than 4 centimeters. And this is obviously a huge difference, but you can see that when we are discussing about selective approach for organ preservation, we pull all these patients together, thinking that this is a selective approach. We select the patient from the beginning. But in case of shared decision making, we need this type of infographic data that we can share with the patient in order to give them a proper view of what they can expect, the rate of response. And if you have a patient with a T2N0 3 centimeters, you can say to the patient the rate of organ preservation, because we will achieve a complete or near complete response, is almost 80%. But if you have a T3N positive between 3 and 4 centimeters, this rate is 30%. Your attitude and the way you will share the decision, obviously, will be completely different regarding these two patients. That's why we think that this paper gives us, as clinicians, a high important data to move to this shared decision making process. At the end, the conclusion is obviously we need to move forward and to push this selective approach in the context of organ preservation. TNT allow us to increase the rate of organ preservation in this paper. And we know that GRECAR12, we have shared the data in FICARE recently, will help to use TNT in organ preservation in a selective way. And at the end, clear infographic data will help us for shared decision making. And this is recommendation of society. When you want to share, to make shared decision making data, we have to use this infographic data. At the end, I invite you to join us for the tripartite meeting in September in Paris. Thanks a lot.
Thank you so much, Quentin. We're now going to make a question and answers sessions regarding this manuscript. Quentin will be happy to answer everybody's question. So if anyone has any question, you can either type it on chat or raise your hand, and we can offer you the microphone to speak directly. I would like to remember everybody that this session is recorded, and it will be available on the Techniques in Coloproctology YouTube channel in a few weeks. I hope so. So I'll start making a question. Quentin, thank you very much for your presentation. After concluding this study, did it change the way you reach your patients, you recommend organ preservation, or it did not change much?
So first, I think that we will keep and we will open the new GRECAR20 trial this month in France, and we will keep the selective approach. But I feel that we will move, in this way of shared decision making, and we have to be very fair with the patient. And we know as clinicians that if you have a T2N0 2 centimeters, the rate to achieve a complete or subcomplete response is much higher, it's significantly higher than in patient with a T3N1 about 4 centimeters. Whereas even in selective approach, we pull them together. So we are moving in this way, even in our new trial of shared decision-making. We are late comparing our urologist colleague with the prostate or gynecologist colleague with the breast cancer. And if we want to share this information, we need proper data like this, saying that, okay, you have this stage, you have this size of tumor. I hope that in the near future, we will be able to use other parameters like biological, and obviously it will be probably more relevant. But at this time, it's quite difficult to use them. But this is quite simple to say, you have this stage, you have this size of tumor, we can expect 80% or 40%. Then using the TNT induction or consolidation can help, I think, and we have this data in GRECAR 12, to improve a bit this type of organ preservation rate in case of patient who is N positive, for example.
Okay, so you've been offering the TNT, or you randomizing your patients to GRECAR 12 when they have early tumor node negative?
So the conclusion we showed in FECARE was that if you have nodes negative, there is no improvement of the organ preservation rate compared to long course chemoradiation. But if you have a T2N1 or a T3N1, we obtain 20% higher rate if you compare induction chemotherapy followed by long course chemotherapy compared to only long course chemoradiotherapy, meaning that you move from 40% to 60%, for example, in T2N1. So our next recommendation, according to these results, will be to use induction chemotherapy in case of a positive nodal status in the initial stages, but not for everyone. If you have a T2N0, we don't recommend it, according to this result.
Perfect. And so in summary, if it's node negative, standard long course chemoradiation. If it's node positive, then you go with TNT. Let's say that you have a patient with a node positive or a suspected node positive that had a subcomplete response after 6 months, and you decide to do a local excision because in the MR, the node is not visible anymore. Would you consider the local excision for this patient, or would you consider a TME for this patient?
No, if you don't see any more nodes in the mesorectum, and if the patient had a subcomplete response, we will consider this patient according to GRECAR 2 and GRECAR 12 for local excision. That's right.
And if there was
we have a question in the chat. So when you're ready,
thank you, Gina.
Let me know.
We'll shortly go to the one last question, Quentin. If there is still something seen in the MR, even though the suspected node in the beginning is not suspected anymore, but is still visible in the MR, would you still consider the local excision, or would you change for TME?
If we consider that there's what we have in our clinical practice is sometimes you have like a small point, like proper fibrotic tissue without any tumoral signal in the mesorectum. We can do the local excision and follow the patient. Obviously, if we think there is still EMVI node positive in the mesorectum in the MRI, then we propose to the patient to perform a TME. Yes.
Okay, thank you. So Dr. Patricio Lin from the US/Argentina is asking, initially congratulations for the paper, and asking why evaluating at 6 to 8 weeks and not waiting a little longer, like 12 weeks to assess the patients.
Sure, it's a really good question. Thanks. First of all, because we think that it's important to assess the tumor response about 2 months. So it's between 6 to 8 weeks, because if you have a good responder, then you can wait for longer, because we know that in this type of patient, probably that we will win at least 20% more of patients with complete or near complete response. But if in the same time, at 2 months, you have poor responder, there is no benefit at all to wait for longer, and probably that it's even worse. For example, if we assess the Rapido trial, we saw that in the same arm, the same experimental arm, you have a better complete tumor response, but you have as well a higher rate of local recurrence. Why? I think that because in the same arm, you have the winner, that means those you wait for a very long time before reassessing the tumor response, because they didn't assess the tumor response at each step. They did the short course and then 9 cycles of chemotherapy and assess everything at 6 months. And obviously you have the poor responder, and if you operate the poor responder very long time after the end of treatment, then the surgery will be more difficult and you will have a higher rate of local recurrence. So I believe, and that's what we are doing in France at least, is we are doing an early 2 months assessment of the tumor. Good responder, you can reassess after longer time, 4 months or 6 months. If you have a bad response or a poor response at 2 months, there is no benefit to wait for longer, and we propose to operate the patient with TME, APR, I mean, removing the mesorectum and the tumor.
Okay, I have one question that has appeared in the Q&A, and then a second one in the chat. The Q&A is from Bruna Valati, and she says the patients received different neoadjuvant treatments. Was there any comparison between patients who underwent conventional treatment and induction chemo in different tumor stages and sizes?
So we show in our data that the patient who received induction chemotherapy had a better response, I mean more complete or near complete response than patient with long course chemoradiotherapy without any induction chemotherapy. Then if we want to, only 25% of our population had induction chemotherapy. That means that if we want to assess patient with different type of neoadjuvant treatment, with different type of tumor stage, then we will have too small group, and it will not be relevant regarding statistical analysis. That's what we didn't do it. But we know with the GRECAR 12 trial, it's not published now, but it will be published, and the results has been shown in FICARE meeting 2 weeks ago, that in case of N0, there is no benefit regarding organ preservation to give induction chemotherapy, but there is benefit, 20%, if you have patient with positive N status. I want to add as well that in our organ strategy, you understood that we pull together local excision and watch and wait. And the other thing is, if you add induction chemotherapy, the rate of complete response is higher, 20% as well. That means that if you have a location of the tumor, intraanal location, for example, you will not be able to propose a local excision. So you want to achieve a complete response. And probably for this type of location, we will push for chemotherapy, either in induction or in consolidation way.
Okay.
So
I would
two further
continue.
questions from the chat.
There's one from Santiago Fontes.
Yeah, so we have one from Dr. Filali from Algeria. So he's asking, in advanced lower rectal cancers with chemo and radio treatment, from what point surgery is performed? I think he means when would you consider operation? Would you consider operation at 6-8 weeks when you assess the patient and there is an incomplete response, or would you wait a bit longer?
So that's what I said, if I understood well, a few responses ago. That means that if at 2 months, 6-8 weeks, we have TRG 1, 2, 3, and with the downsizing as well, we will wait for longer. If at 6, 8 weeks we have TRG4, TRG5, no response or poor response, we propose surgery. And then obviously we rarely discuss about it, but the type of response is important. Obviously, if you have initially a circumferential lesion, at the end you will have a stenosis. It will be difficult to assess the response, so we will propose a surgery. And if you have mucoid or colloid response as well, it will be really difficult to know what happened inside, and so we will be more in favor of TME as well, and we will not propose, or really rarely, organ preservation in this type of response as well.
Thank you. So next question is from Dr. Santiago Fontes. He's a medical oncologist. He's congratulating you for the presentation and is concerned about over-treating these tumors. So just to clarify, when you're recommending TNT, you're using FOLFIRINOX. And his question is, he would like to know if you have any data on secondary effects such as oxaliplatin-induced neuropathy.
Yeah, it's a really good remark, and obviously we all ask this question about over treatment of small lesion. When you are discussing about T2 and 0, you can do surgery upfront without any treatment. But I fully agree with you. What we can say is in GRECAR 12, I mean, we gave 4 cycles of FOLFIRINOX. In GRECAR 4 as well. In PRODIGE 23, it was bigger lesion. But what we know is that observance of in the treatment in induction chemotherapy is higher than 90%. So that means that patients accept this treatment. Then obviously we had some neurotoxicity with oxaliplatin. It's important, and that's why we have to share with the patient. When we are discussing, we are moving more and more to TNT, either by induction or consolidation, whatever, in rectal cancer management. But what we have to discuss now is how to de-escalate. And de-escalation means either no surgery or no radiation. We rarely discuss about avoiding chemotherapy. That's why with the results we will show with the GRECAR group, and I'm sorry because the sample is too small in this paper, but this paper move and give some information in order to have a proper discussion with the patient and being able to tell them that if you have this type of lesion and this size, you will have this type of tumor response and organ preservation. But induction chemotherapy or consolidation chemotherapy should not be given to everyone. I fully agree with you. And that's why if you have a T2, T3, and 0, GRECAR 12, and I hope that the paper will be published within the first 6 months of next year, we will not recommend induction chemotherapy and only long course chemoradiation in order to avoid over-treatment. But I mean, we have more and more data now, and we should be able, with all this information, to propose either radiation or surgery or chemotherapy, but trying to decrease the rate of TNT, because otherwise we will move for all the patients in the same way, TNT from T2 to T4, and I fully agree with you that we will over-treat a lot of patients, and we should avoid this way of treatment.
Do you believe there is room for less drugs instead of giving FOLFIRINOX, giving, for example, only capecitabine, and perhaps giving this patient also higher chance of organ preservation? Any experience with this, or usually FOLFIRINOX for all cases of TNT?
No, we use in France FOLFIRINOX. Obviously, we have some patients with FOLFOX when they are more frail, but I don't have any experience only with capecitabine. We have some patients with only FOLFOX and not FOLFIRINOX, some patients with consolidation, but we have expertise from other trial, other country, but we can share in FICARE as well the NEO trial, with chemotherapy and without any radiation, with local excision after chemotherapy only. So it's a lot of questions. We have more and more data. This is and then we need to compare all these treatments in order to tailor all of them, because we can't propose all treatment will not fit everyone.
Perfect. So next question is from Dr. Schrappen, Cedric Schrappen from Belgium. He's concerned about why not giving chemo after chemoradiation. So his question is, what is your opinion on using consolidation chemotherapy instead of induction, given the prolonged response of the tumor to the radiation therapy and higher response rates using consolidation in some trials as the upper trial?
Yeah, so it's same. I mean, it's good, very good remarks. Thanks. We always compare induction and consolidation. We have no proper trial comparing them. You talk about OPERA trial. OPERA trial was the phase 3 or phase 2 trial, not the phase 3, and the primary endpoint was disease-free survival, and there is no difference at all. So at the end, a secondary outcome, but the trial was not designed for this. The authors showed that there is more organ preservation in consolidation. What we don't know at all is it the consolidation chemotherapy, or is it the longer time after radiation? Because they decide 8 weeks after chemoradiation in the induction group and 28 weeks in the consolidation group. And we know that if you have a good response, waiting for longer helps to achieve a more complete or near complete response. So we don't know at this time if this is a consolidation chemotherapy or it is just waiting for longer in this patient with good response. And so I can't answer. My feeling is that for mid-rectal cancer, using induction chemotherapy can allow you to stratify your strategy after, meaning straight to the surgery after induction chemotherapy to avoid radiation in order to improve the function, or doing chemorad in order to avoid surgery. But for lower rectal cancer, it's different. We know that when you are within 1 or 2 centimeters above the anal ring, almost 100 of our patients will have radiation. So for this type of patient, I believe that we have place to give chemoradiation first and consolidation then. So that's why there is no definitive answer. I think that we don't have the answer comparing induction and consolidation, not strong data in the literature. And at the end, I think that we have to differentiate mid and low rectal cancer, whereas usually we consider them like a proper entity, same entity. And I think that the problems are completely different and we have to treat them probably in a different way as well.
Perfect. So next question from Dr. Nicolas Bittencourt. Did you assess tumor histology? Any difference with mucinous histology tumors in your numbers, in your data presented here?
No, we don't have mucinous because we can't consider we don't consider in 99% of cases, we do not consider mucoid or colloid response for organ preservation. So we did not include this type of patient in this study.
Okay. Dr. Filai from Nigeria has another question for you. I'm gonna read out what he has written. A technique that is being evaluated in France by a renowned professor with the use of indocyanine green, where mesorectal resection is not practiced. He performs a picking of all positive adenopathies under ICG with very promising results. I never heard about it, but I would love to hear from you. What do you think? Are we going to revisit the question of complete mesorectal resection one day?
So I think that you are talking about Philippe Rouanet, and I share with him. He shared with me his video. We discussed about it, and we discussed in our GRECA group. So it's a little bit different. He used this if we are discussing about the same things, but I think so. He discussed about the patient with endoscopic resection, and with poor features, meaning SM3, embolism, buddings, and should require complementary TME. And what he performed in less than 10 patients, so it's difficult to say that it's oncologically promising. It's more experimental. He put some ICG in the scar of the submucosal dissection, and then the day after, with the robotic approach, he do a mapping with the ICG, and he removes all the nodes. But I think that it's really too early to propose this. Then I'm really worried about the fact that if you should do a new, because he avoid to do complementary TME. That's true. He preserve, he just remove some nodes. But then if you have a recurrence and you should do a TME, I can say that it will be probably a nightmare. So I think that we don't have enough data. It's really like, preliminary results in a really small number. It's not what we are talking here after chemoradiation or induction or consolidation chemotherapy. It's more for early rectal cancer, removing by endoscopy, and then we should perform a complementary TME. But then we have the response because, part of the response with the TESAR trial, it should be published next year, I think, as well. But we have the results presented in few meeting showing that if you are doing a complementary radiation in this type of patient, at the end, the rate of local regrowth and distant metastasis will be the same that if you are doing a complementary TME. I think it will be safer than doing this picking node strategy. I think so, but it's not my opinion.
Perfect. Thank you. Quentin, one last question that I have for you. So the majority of the patients you've included in your study is a kind of patient that probably would be recommended upfront TME from the oncological point of view, according to the ESMO guidelines. How do you select these patients today to offer then either TNT or long course chemoradiation for the solely purpose of organ preservation? Do you consider tumors up to 8 centimeters, or do you prefer lower tumors? How would you select these patients?
So we select patients below 8 centimeters from the anal verge. The tumor should be palpable. We do not include patients with high rectal cancer. Then we for organ preservation, we keep the criteria from GRECAR2 and GRECAR12, T2, T3, N1, N0. We don't keep the patient with N2, for example, or with circumferential lesion, or with lesion size of the lesion about 7 centimeters. The maximal size is 4 centimeters. So we keep this selective approach in patient with a lesion lower than 8 centimeters. Does it answer to your question?
Yes, thank you.
Yeah. Okay.
So does anybody has any further questions for Dr. Denost? In this case, thank you so much for sharing your expertise with us today. We know it's quite late in France right now. Thank you, everybody.
Guilherme, and thank you all the team from Technics for this opportunity.
Thank you. And thank you, everybody who stayed connected with us. Dina, I think we're finishing the session. Thank you very much.
Yes, this was an excellent back and forth question and answer session. Very interactive. Thank you both.
Bye-bye. Thank you.
Bye-bye.
Bye. See you.
Thank you for watching. Be sure to subscribe and join us for our next virtual session here at youtube.com at Tech Coloproctal.